let me take you to the discussion of anal fissure. Anal fissure. Now, what is fissure? What do you mean by fissure?
Surface, I mean tearing.
Exactly.
Tear in the mucosal layer.
Exactly. You're right. Absolutely. Fissure means tear. Okay. Tear in that anal area is called anal fissure, and this is a very painful condition. Okay. And so many of the patients suffer from this. So let us talk about it. An anal fissure is a crack or tear in the wall of the anal mucosa so that the circular muscle layer is exposed. See there, crack in the wall of the anal mucosa so that the circular muscle layer is exposed. The tear usually occurs directly posteriorly and in the midline. This is the most common site for the tear. And this knowledge is important for us because when we examine this patient, if we see tear or crack there, we can diagnose this is the case of anal fissure. Regarding the sex, both sexes are equally affected. The peak incidence is in the 20 to 30-year-old age group, but it can occur to anyone. Now, what is the etiology here? The most common cause of an anal fissure is the passage of large stool after a period of constipation. Now, this is a very important point. So let me highlight this. Passage of large stool after a period of constipation. The patient may be constipated for a few days, 3 to 4 days, or even 4 to 5 days. People have that type of habit. And then they want to go to toilet. Now they cannot even control it. They suddenly release large amount of stool, and that stool is harder, and they release it with a lot of pressure. That should not be done. They should control the release of fecal matter, especially in case of constipation. Otherwise, there is tearing of the mucosa resulting in fissure. Other causes include Crohn's disease, okay, and as a result of sexual abuse in case of children. Okay, sexual abuse is is increasing everywhere in the world these days. This is a part or type of child abuse. Okay, there may be tear and Crohn's disease. It's a type of inflammatory bowel disease. Okay, Crohn's disease. Remember, there is involvement of the GI tract. The whole GI tract is affected in Crohn's disease. So it may also involve the anal canal region. Now, let's talk about the clinical feature of anal fissure. There is history of painful defecation. This is quite prominent if we ask the history properly. Painful defecation. Patient has suddenly passed the stool, and during that time, they suffer from severe pain. The passing of hard stool may cause sphincter spasm and pain, which may persist for up to an hour. After that fissure is formed, every time when the patient goes to toilet or goes for defecation, there will be pain. When the stool is passing from that area, there will be pain. And patient is afraid to pass the stool. Patient is afraid of defecation. This is quite typical feature of anal fissure. And remember, when they are afraid of defecation, they will suffer from constipation again because stool is collected there. So this is some type of vicious cycle. Even sitting may be avoided sometimes. There is often fresh rectal bleeding at defecation, and the patient complains of bright red blood on the tissue paper. So that's why it is considered as a very important differential diagnosis of hemorrhoid. But when we compare between these two things, hemorrhoid has more bleeding than pain. Okay, internal hemorrhoid, they don't have pain, remember that. And this anal fissure is a very painful condition, but bleeding, just a small amount of bleeding, okay, on the paper. Look at this picture here. So this is what it looks like. There is a tear here, okay. This, because of this a tear or this pathology, this anal sphincter is having very increased tone. So when I do digital rectal examination through this anal opening, we can feel this sphincter is contracted, and this is considered as one of the very important sign of anal fissure. But if we see this, the diagnosis is almost confirmed. Another one, see here, anal fissure. Now on examination, what we see, there is a longitudinal tear that nearly always occurs directly, posteriorly, and in the midline. This is the most common site for anal fissure. Now, one of the very important point from the exam point of view is sentinel pile. Okay, what is the sentinel pile all about? Now, see there. The sentinel pile means, okay, when the anus is inspected with the buttocks gently parted, the sentinel pile may be seen there. It is a bunched up strip of mucosa at the base of the fissure. And this is a chronic type of fissure now. In acute fissure, we usually do not see sentinel pile. So this strip of mucosa is a bit of bunched up there, it is a bit of present like a skin tag, actually present like a skin tag there, but it's not really skin, it is a strip of mucosa there. And this is a very important feature of chronic type of anal fissure. The severity of the pain and muscle spasm may preclude digital examination and necessitate examination under GA. The patient is having so much pain and muscle spasm that the digital examination of the rectum cannot be done properly. Patient even doesn't allow you to put your finger there because of too much pain, okay, because of hesitation that it will cause pain. So sometimes even general anesthesia is necessary to examine that area properly. Now, this clearly tells us how painful the condition is. Now, how to manage it? A bit similar to the conservative management of the hemorrhoids, because the mechanism is same. Remember, hemorrhoids is also associated with constipation. This is also associated with constipation. And here also there is increased spasm of the anal sphincter. And there also the anal sphincter tone is usually increased. So some of the treatments are similar. We should introduce more fiber into the diet together with laxative and analgesic suppository. So this is important one, just to make that stool softer, increase fiber in the diet. And this is acute situation most commonly. So give laxative for few days. That poor fellow is having a lot of pain, so make that stool softer with the help of laxative. Okay, you all know. Can you give me some of the examples of laxative?
Bicacid,
Isabella husk.
and Sena compounds.
Good. Exactly. All of
Crocodile.
yes,
Relax.
exactly. All of the
Crocodile,
names
sir.
which you
Sena
are
and Besacodal.
exactly. Bisacodile, isn't it? Dolclax and all those things. Even glycerin suppository, all those things can be used very commonly here. Very good. And this is a painful condition, so give analgesic suppository. Suppository means the form which is kept in the rectum. Suppository. So these really help the patient. Topical glyceryl trinitrate is one of the very commonly used treatment here because it relaxes the anal sphincter and it is present in the topical form. The patient can apply it there. Another modality is botulinum toxin injection. So just like in hemorrhoid case, we can also give it there. Now, what about the surgical treatment? See there? Now, surgical treatment can bring immediate relief, and this is done by internal sphincterotomy. Internal sphincterotomy means you divide the internal sphincter, you cut the internal sphincter. That is the point. Okay. We cannot cut the external sphincter, because external sphincter is the main control there, it's a voluntary control. But rather, if we divide the internal sphincter, then the passage of the stool will be easier. And they have done different study, okay, and the studies show that the healing rate was 90 to 100% after internal sphincterotomy. So this is a good type of treatment here. And another one is manual dilatation. Manual dilatation. Okay, you dilate that anal sphincter, and it reduces the sphincter pressure. It results in better healing. It results in incontinence, though in some of the patient, if this dilatation is uncontrolled, okay, just like Lord's stretch maneuver, okay, it can lead to incontinence, and it is rarely indicated if we go for internal sphincterotomy. This is just one of the options there. Remember, it should always be done under general anesthesia. So this is all about the discussion on anal fissure. So let me summarize it in few sentences. Anal fissure is a very painful situation. It is usually caused by constipation, especially when the patient pass large amount of constipated stool, okay, without any control. That can tear the mucosa there, which results in fissure. Very painful condition. Patient hesitate to go to defecation. The pain is so much severe, and when they are about to defecate, okay, there is persistent spasm of the anal sphincter, so that passage of the stool is a problem. So when the examination is done, we can see a fissure, is tear of the mucosa, especially on the posterior and the midline side. Okay, in a relatively chronic type of cases, a sentinel pile also can be seen. Digital rectal examination is very painful procedure here. So I will always check what is the tone of the anal sphincter first before going for it. And if it is necessary to do, then do it under general anesthesia. Regarding the treatment, conservative treatment is very commonly done. Okay, like we can apply the topical glyceryl trinitrate cream there to decrease the tone of the anal sphincter. You can go with some laxative to make that stool softer. You can ask the patient to modify their dietary plan, increase the fiber containing diet, okay, and take a lot of fluids. These are the different points there. And even botulinum toxin can be tried. Regarding the surgical management, internal sphincterotomy is the one. So with this, let us go to the another small topic, which is known as anal fistula, also known as perianal fistula or fistula in ano. It's a very commonly used term, fistula in ano. Now you all know what is fistula, isn't it? What is fistula in this case? Yes, in this case, what is fistula here?
There is an abnormal connection between the anal canal and rectum, sir, with the exterior perianal skin as well, sir. Is anal fistula or fistula ano.
Fistula is the developed between the in of the bowel and the skin near the anus.
Good, good. Yes, absolutely. Okay, so the concept is there, because we have already taken an extensive class regarding sinus and fistula. So every student know the meaning of fistula here. Fistula is a connection between two lumen, okay, two lumen. So we are talking about the GI tract here. So one opening should be in the lumen of GI tract, and another opening is usually to the exterior, means on the surface of the skin. This is known as anal fistula or perianal fistula or fistula in ano. It is around the anal region. The inner opening, okay, can be in a different area of the anal canal. The outer one is usually on the skin. Okay, so let's start the topic. Anal fistula is an abnormal communication between the perianal skin and the anal or rectal lumen. Okay, sometimes the opening is even higher up in the rectum, but usually it is in the anal canal lumen, and the outer is on the perianal skin. So this is fistula. It may occur as a complication of an anal abscess that has burst onto the skin, or it may occur after incomplete surgical drainage of the abscess. So this is a very important knowledge for us. So many, okay, of the patient, they develop perianal abscess, perianal infection or perianal abscess, and the important treatment here is drainage. Okay, if it is incompletely drained, it can lead to fistula. If it bursts inside and outside, there is a connection development, or if it has burst on its own even without surgical drainage, that can also lead to fistula. So the lesson to be learned: do not ignore any anal abscess or any infection around the perianal area. Seek the attention of the doctor quite soon. Now let's classify perianal fistula or fistula in ano. If the internal orifice, see there, if the internal orifice of the fistula begins below the puborectalis muscle or the sling of puborectalis muscle, then this is known as low fistula. If the internal orifice begins above the puborectalis sling, then it is described as a high fistula. And high fistula, okay, are more complicated one. They are complicated. The treatment of high fistula is a difficult one than low fistula. High anal fistula are much rarer than low fistula, and they usually occur in a condition known as Crohn's disease. Now, you have studied Crohn's disease before, maybe in the internal medicine, but I'm not sure. If you have not studied, you will study very soon in the GI system. Crohn's disease is a part of inflammatory bowel disease, just like ulcerative colitis. And in Crohn's disease, the incidence of fistula in the GI tract is very, very common because of transmural inflammation of the wall, much more common than ulcerative colitis. It may result from a foreign body also there. Okay, foreign body in the GI tract may be present sometimes. The management of a high fistula is more complex than that of a low fistula. We'll talk about that during the management part. Now, what are the clinical features of anal fistula? How the patient present? The patient with a perianal fistula or fistula in ano complains of intermittent discharge in the perianal region, leading to perianal discomfort and chronic irritation. Now there is a connection there. There is a, isn't it, tract there. The inner opening of the tract is in the anal canal or even the rectal lumen. So some amount of fluid or some type of fluid is always coming outside there and making the undergarments soiled. Okay, and then patient will have discomfort, a bit of itchy type of sensation most of the time. On examination, the external opening of the fissure is generally seen. Okay, this fistula, okay, it may present as a bit of fissure outside, but usually it may be rounded also. It is seen lateral to the anus, lateral side to the anal opening. The external opening may be seen as a small papilla of granulation tissue. Sometimes it may be seen as a solid tissue there, the real opening may not be seen, but when we separate it, then the opening can be visible. The internal opening to the fistula may be felt on a rectal examination because it is relatively harder area there. So when we do digital rectal examination with the tip of the finger, we can feel the inner opening of the fistula on the surface of anal canal or the rectum, and outer can be seen. Now let's see some of the picture here. Now look here very carefully. So this is the opening of fistula. If we examine with a little bit rush, means we don't have enough time to look for these, it can be easily missed. So it should not be missed. See there, there's a small bulged area there, and if we feel it, it feel a little bit hardened area there. But if we separate this with our finger, we can see a small opening there. This is the opening of the fistula outside. Now inside, we should put a finger inside. This is called digital rectal examination, and we can feel the inner opening with the finger. It is inside the lumen. This is another picture, okay, which is showing the fistula here. This is fistula. Okay, now see this. They have passed, a bit of, a tube, a small tube here, or you can say, catheter. Okay, catheter, and this catheter is nicely passed from here, and the tip of catheter has gone inside the anal canal. So you can clearly see this is a passage of the fistula. The fistula tract is very clear here. Now, what are the examination finding? Examination with proctoscope may allow direct visualization of the internal opening. So proctoscopic examination is always done. Proctoscope is an endoscopic examination of the rectum. It may be possible to pass a probe along the course of the fistula to chart its pathway. It is quite safe, okay, to pass a probe in fistula. But in sinus, remember, it may be quite dangerous, because sinus may be converted into fistula if we do not take care of where the probe is going. If you forcefully put the probe inside, it may turn sinus into fistula tract. Now, there is one important point here, that is known as Goodsall's rule. What this Goodsall's rule is all about? Now please pay attention. This Goodsall's rule is applied to the examination of anal fistula. Fistula with an external opening in relation to the anterior half of the anus tend to be of the straight type, and fistula with an external opening in relation to the posterior half of the anus tend to be of the curved type. Okay, so let me make it clear to you. Now we are examining the external opening, definitely. Okay, so external opening is seen anterior to the anal opening, anterior to the anal opening. If it is there, then the internal opening of that, okay, fistula tract, okay, is somewhat straight to that. Means the total tract tends to be a straight type. It is not complicated type. Whereas if the external opening is there posterior to the opening of the anal canal or anus, then it is of the curved type. Means the internal opening is a little bit, not in a straight line. It is a little bit on the right or on the left or even the upward. Okay, this is a curved type. So all of you, please focus here. This is the Goodsall's rule. Now see this. So these are the anterior opening. The external opening is anterior. Okay. So the tracts are straight. They are the straight one. And these are the posterior, external opening. And when we pass a probe here, so it is a curved type of fistula, curved. You can clearly see here. So let me repeat again. The fistula tract, okay, where the external opening is anterior to the anus, it tends to be a straighter type of fistula, whereas if the external opening is posterior to the anus, then the fistula tracts tend to be curved type or a complicated type of fistula. So this is known as Goodsall's rule. Now, how to do the management? Okay, how management is done? Let's talk about it. The form of management of an anal fistula depends on whether it is a high fistula or low fistula. Now, let us repeat again. High fistula means the internal opening is above the puborectalis muscle, whereas a low fistula, the internal opening is below the puborectalis muscle. And puborectalis is the muscle which is elevating, okay, elevating that area like a sling, and it is maintaining the continence of that area. So this is a very important muscle there. Management of a high fistula is more difficult because anal continence is maintained by that muscle, okay, and the external anal sphincter as well. This mechanism is at risk when high fistula is operated on. Sometimes we need to cut that muscle, and after that, the continence is in a problem because external anal sphincter and puborectalis are maintaining that, and the opening, the internal opening of the high fistula is above them, so they may be damaged during the operation. Whereas regarding the low fistula, the treatment is relatively easier, and the principle of treatment of low fistula is we lay open the fistula. Lay open means we cut that fistula and keep it open so that over a period of time, it will be fibrosed and that lumen is gone or obliterated. This is the mechanism. So we're talking about the management of fistula in ano. So there are two types of fistula here, high fistula and low fistula. High fistula means the internal opening of the fistula is above the puborectalis muscle, and low fistula, the internal opening is below than that. High fistula management may be complicated because, during the surgery, that puborectalis or external anal sphincter may be damaged. So the continence can be a problem, but with the experienced hand, that may not be the problem. Whereas a low fistula, the principle of management is laying open the fistula. Okay, it is called laying open the fistula. So what does that mean? Let's discuss in a bit of detail. The operation involves laying open the fistula. A probe is carefully inserted into the external opening and passed into the anal canal via the internal opening. Now, you have secured, or you already know what is the fistulous tract here. So after that, the tract is completely laid open by cutting down on the probe. We just incise, okay, that area and leave it open. If there are any lateral extension, then these must also be laid open. After that, okay, slowly it will heal, it will get fibrosed, and the tract will be obliterated. The patient will be in hospital for around 3 to 10 days after the surgery. Let's move on. Now, in case of high fistula, okay, there is some other way also. Okay, some other way. Now see here, operative management is one of the way, which is more complex and highly specialized. So very experienced surgeon should do this type of surgery. Otherwise, they can easily damage the continence mechanism of the anal canal. Complicated high fistula may warrant a proximal colostomy. Now, colostomy should be maintained there because during that time, we should give rest to that part of the bowel where the surgery is done. If stool comes in contact with that part, then probably it will not heal in time. So colostomy may be necessary so that stool is passed out from there. Colostomy is made an opening on the anterior abdominal wall and the loop of the bowel is sutured there. It is possible to use a chitone. Okay, chitone is a ligature of, see there, is a ligature of silk or linen, and this is to lay open an intersphincteric tract. Okay, this is a chitone type of treatment. This chitone remains in situ and it acts as a wick or drain, and it also allows the acute inflammatory reaction to occur around the tract. Okay, and this simplify the subsequent surgery, or if it is kept for a longer time because of the chronic type of inflammation, it can also result in fistula fibrosis and results in obliteration of the fistula. So these are the different way of managing the high fistula. So one is definite surgery. Okay, very experienced surgeon has to do it. Second is, during that surgery, colostomy may be necessary. Third is a chitone type of treatment. Chitone is a ligature of silk or linen, which is inserted into the tract, and it is kept there for a shorter duration or a longer duration. After shorter duration, subsequent surgery will be easier. Okay, and after we keep it for a longer duration, it may itself act as a treatment. So these are some of the important points regarding chitone.